Hi, everybody. Welcome. My name is Sarah Klupane. I'm the Boone County Hospital Foundation Director, and we have another month of our Educating and Empowering You series that we're sharing today here with Dr. Mahoney from Iowa Ortho. So before I turn it over to him, I just want to do a reminder or send out a reminder to our listeners that we will have a monthly program each month through the rest of the year. Next month, we will have Iowa Donor Network. We have not had them sharing with us for a while, so we'll be learning some of the new latest and greatest with organ donation and what's going on there. So please look for that to be in your social media or other news outlets coming up. So also, before we get started, I just want to let everybody know that if you have questions, please feel free to put them into the chat. I will also be jotting down questions as I go and ask Dr. Mahoney at the end. But we do want to make sure that we address questions that people might have. So I'm really just happy to have you again, Dr. Mahoney. It's been a while since we've also visited here in this format, and it's always fun to hear about the fascinating updates in technology with orthopedics. So without further ado, I'll turn it over to you to share more about yourself and what's happening in the world of Iowa Ortho and orthopedics.
Great. Sarah, thank you for that nice introduction. Craig Mahoney. I live currently in Des Moines. I've been coming to Boone County Hospital, I believe, for 19 to 20 years. I enjoy coming up here. My wife was born and raised just west of here on a farm, so we both love Central Iowa and Boone County, and I feel privileged to be able to take care of people from this area. We do non-operative as well as operative treatment for people with knee and hip arthritis. I also have partner Steve Avilas, who's a sports medicine specialist, who takes care of knee, shoulder, and hip problems from a sports medicine standpoint. And then Ben Paulson, who is an Ogden native who does hand and upper extremity surgery. So today, just going to talk a little bit about knee replacement technology, some updates, and some things that may stimulate interest in what we're doing. Disclaimer is the information that's been provided is primarily through the company that I use for knee replacement here at Boone Smith & Nephew. I'll talk about the information, and these are somewhat opinions and may or may not reflect the Smith & Nephew's points of view, but it will reflect my 21 years in practice. So to start out, just talking about the knee, basics of knee and knee anatomy is, the upper part of the bone in the knee is the femur. I think if you can see my cursor, that's the femur on top. The shin bone is the tibia on the bottom. The medial and lateral collateral ligaments is a medial collateral ligament right here, lateral collateral ligament here. The patella or kneecap is in the front, and that's kind of what helps us power, stand up from a chair, etc. It's a hinge joint, but it's actually more complicated than that. It does bend back and forth, but it also twists and is really a complicated joint once you start to read about it. The menisci are these sort of figure of eight pieces of fibrocartilage that are hinged, or rather attached in the middle, and circle around the lateral or outside aspect of both the medial and lateral joint line, distribute force. Some patients we see have meniscal tears, and that's more common as we get older. The anterior and posterior cruciate ligament are depicted here, and those provide stability anteriorly and posteriorly. So a lot of what I take care of is arthritis. Excuse me. And so you see a normal knee on the left here with the bluish area depicting normal articular cartilage, the meniscus in the middle, and a space between those two bones that we often see on an x-ray. And what you see on the right side is an arthritic knee. These areas of roughness here are bone spurs. The areas of cartilage loss depicted here as these geographic spots where there is no cartilage and there is narrowing of the joint space. So that's what we see in people who have arthritis. So arthritis refers to a breakdown of that cartilage. Knee arthritis is the most common form of arthritis that I see, certainly. And arthritis in general is the most common form of disability in the United States. Close to half the people by maturity or by death will have experienced symptoms of knee arthritis. So it's incredibly common. Most commonly, people complain of pain, either with movement or without. Patients will oftentimes come to the office with stiffness and may have swelling. And the reason we see it and the reason we treat it is that people want to maintain normal activities throughout their lifetime. Want to continue to walk. I see some patients that have trouble walking. They have limitations in motion, which will keep them from dressing effectively or appropriately. And also, when most severe, will affect their ability to sleep. And I think that's a real differentiator for people with arthritis. Early arthritis depicted here on the left shows some just a little wear and tear, no real bone spurs. This would be kind of a grade 1. Grade 2, where you start to see these bone spurs here, maybe some narrowing of the medial compartment of the knee, and then of course grade 3. And those folks have significant limitations in activities, have pain with most activities. And typically we see in people with severe arthritis both on the inside, outside of the knee, but also under the kneecap. Non-surgically, if you've seen me in clinic or if you've seen a doctor, they may or may not have recommended the above, and these are in no certain order, but many of us struggle with our weight as we mature. Our metabolic activity drops as we get older and our muscles get weaker. We're less active, and so weight can become an issue. Weight control, weight loss can be a very effective way to treat arthritis in the knee. Lifestyle modifications such as limiting stressful activities, using low impact exercise, those things are effective. Anti-inflammatory medications, ibuprofen, Aleve, over the counter, Celebrex, meloxicam, others that are prescription strength. Physical therapy and exercise are very effective, and also steroid injections, or in an appropriate patient that is not tried it, we can try hyaluronic acid injections or even do platelet-rich plasma injections. Multiple research studies show that exercise is an optimal treatment for arthritis. Exercise is an anti-inflammatory activity when done appropriately, maintains flexibility, decreases weight when necessary, and generally speaking, in most forms can help people with arthritic symptoms. We talked a little bit about the medications. The over-the-counter medications that we typically recommend, anti-inflammatory medications, are the most effective way to treat arthritis if you tolerate them. Of course, there are side effects, stomach problems, kidney problems, heart problems. Tylenol or acetaminophen is very safe when taken as directed. That's over the counter. Topicals are easy to use and relatively safe. Voltaren gel, things like that. Aspirin cream can certainly help with some symptoms. We talked a little bit about corticosteroid injections. I don't recommend much in terms of oral steroids. Some people do. Narcotic pain relievers, opioids, are primarily in our practice reserved for those folks who are recovering from surgery. They're not an effective way to treat standard arthritic changes. As I mentioned above, many of the medicines that we use do have side effects, so it's up to your doctor, whether it's me or your primary doctor, to monitor those side effects and be checking on things that could take place if you use those medicines chronically. You can also use heat or cold effectively, depending on the specific situation. Surgical options. Arthroscopy is primarily used for those folks that have meniscal problems. Arthroscopy as a primary tool for arthritis treatment is not effective. Partial knee replacement can be used here in the middle, and that's done in situations where only one compartment of the knee, in this setting, the medial compartment, is arthritic. If the lateral compartment, the patellofemoral joint, are normal, then we can just do a partial. But of course, the most common thing we do is a total knee replacement, you see depicted on the right here. Many patients come in, they say, I want a knee replacement, and then of course, so we evaluate them, and some patients are appropriate, but some are not. So if you're contemplating knee replacement surgery, I think the things that the doctor would probably ask you would include things like, how severe is the discomfort? I would like to see patients who have severe changes in their day-to-day activities when considering knee replacement, just because there are other things that we've discussed that we can do. Rest pain or night pain is a differentiator for a lot of people. So if you can't sleep because of knee pain, that would be something that would motivate me to consider knee replacement. Patients with chronic inflammation that's recalcitrant to non-operative treatments, and failure of all those treatments is another indication or another situation where we may consider knee replacement. Once knee replacement has been done, we often recommend physical therapy. Boone County has a wonderful physical therapy department. I have complete confidence in their ability to help my patients and refer to them preferentially. I think they do a great job. They're hands-on. They communicate with me in terms of how my patients are doing or things that may be beneficial. But the recovery is facilitated in my mind by physical therapy. Once patients have healed from their therapy and their surgery, we encourage patients to get back to low impact exercise such as swimming, walking, or bicycling. And that's actually part of the recovery. So interestingly, most of the recovery occurs in that first 2 to 3 months, but people will actually maximally report improvement up to a year to 18 months after surgery. One of the products that we use here in Boone County is the Smith & Nephew OXINIUM knee, and that is a knee that has been designed to last longer, to give patients a better chance at having their first knee replacement be their only knee replacement. Things that I worry about and I talk to my patients about prior to surgery as risk would include infection. That's obviously the number one thing we worry about, and we do a lot to try and get in the way of that. But the implant materials are really important as well, and that's conceptually where the concept of OXINIUM comes in. As surfaces rub together, they break down, and the portion of your knee that acts as the portion of your knee replacement, rather, that acts as your new cartilage is the plastic in between. And historically speaking, wear of that plastic, or what we call polyethylene, has been an important failure mechanism. And you see that plastic depicted right here on the right side where my cursor is. So friction can break that down. If the surfaces are rough, they will break that plastic down more quickly. If implants are placed incorrectly, if they're crooked or not balanced correctly, that can contribute to wear. So those are the types of things that are sort of under my purview and things that I worry about and try and really take care of at the time of surgery, making sure that we don't scratch the implant and put it in an appropriate angle. Implant wear shortens the lifetime of the hip, or the knee rather. So if it's wearing out, that means there's a higher likelihood that I'm going to have to go back, or someone's going to have to go back and redo the joint. And we don't want to do that. We want a single surgery to be the only surgery that our patients have when we're considering knee replacement. If the plastic breaks down, we get concerned about something called osteolysis, and that's a reaction in the bone that stimulates the osteoclasts, which are cells in our bone that actually chew up bone or help us reformat our bone. They become overactive in the presence of tiny plastic particles. So this osteolysis can lead to early loosening, instability, and increase the risk of revising the knee. The OXINIUM implant you see depicted here has a lower coefficient of friction. So it is smoother and more wettable than a standard cobalt chrome knee. And because of that, the lab data would point to a longer period of time of wear with an OXINIUM knee when compared to a non-OXINIUM knee. The plastic that's used now is cross-linked, so it is more resistant to wear than it has been in the past. And those technological advances have been done by this company to try and decrease the risk of revision knee surgery down the road. How is it made? Well, zirconium is an element. It is similar to titanium. And if anybody out there is familiar with metallurgy, titanium is a very biocompatible metal, but it's very soft. So it does have a high coefficient of friction. So when we press normal titanium or normal zirconium against plastic, it will wear out relatively quickly. But Smith & Nephew has been able to use their technology to create a surface on the outside, or create a hard and very wettable and very smooth surface by heating the implant made of zirconium in the presence of oxygen. So they call this surface ceramicized. So the surface actually feels and wears like a ceramic, which is very wettable and very low friction, but isn't hard like ceramic. So these OXINIUM components won't ever break. They've done extensive lab testing after 5 million simulated steps. So they actually literally, if you could see in a lab, have a knee moving back and forth. After 5 million steps, the wear was reduced by 98% compared to implants that were made from non-OXINIUM material. They continued on to 45 million steps and still showed significant decrease in wear, to the point that they have stated that the wear would be reduced by 81% in someone who had 30 years of their knee replacement. So really an impressive improvement in their wear technology. One of the specific designs then, so the material is called OXINIUM, but the specific design of this implant is called the Journey 2. And this is a more recent implant that's been released by Smith & Nephew. And it is designed to make your knee feel more normal. So the science behind knee replacement is keeping the bones from rubbing on each other and doing it in a way that makes your knee feel normal. Historically, knee replacement has been very successful, but if there is a concern, some people feel that their knee doesn't feel like their normal knee. And so there have been many technological advances and studies and designs and redesigns trying to create a knee that feels like a normal knee. And the Smith & Nephew answer to that is the Journey 2 knee, which you see here on the left. It does recreate more normal motion, can help accommodate deep flexion, and also it is made of that OXINIUM material that we spoke of before. So how did they do it? Well, they used a simulator, and the engineers were able to build and test hundreds of thousands of designs in a simulated fashion, and then watch those implants move in space to try and match what we see in a normal knee. When they did that, they felt that this Journey 2 design recreated the anatomic shapes to the best of their ability, and felt like this was matched to most physiologic situations. Again, I mean, our goal being, Iowa Ortho and Craig Mahoney, is to have people feel their highest level of function after surgery, after they've recovered, and get the most motion. With still good stability with the knee, and then reattaining your strength after you've recovered. The goal really is to have people forget about their knee replacement. So, the highest compliment I think I can hear from a patient after surgery is that, I don't even think about my knee anymore. It feels like a normal knee. That's our goal for everybody. And I think having a good implant can help with that. The curve here that you see, this line, is designed to match the front of a normal femur. There's a little bit of what we call this S curve that exists in all of us. And this allows our kneecap to track more normally, and does, based on multiple studies, allow us to achieve deeper flexion and minimize pain in the front of the knee. So, when someone comes into the clinic here in Boone, we really focus on treating the patient and not necessarily just signing patients up for surgery. Not everybody I see is a candidate. I saw people here this morning. Many of those patients I have recommended not to have knee replacement because I felt there were non-operative treatments available to them. But I think for those patients that fail non-operative treatments, knee replacement is a great option, and in the vast majority of cases will decrease pain and improve mobility. anytime we do a knee replacement, we want to make sure that we minimize the risk associated with the procedure. Infection is the number one thing we worry about, but we also, want to make sure the implant stays fixed. We don't want anybody to fracture afterwards, don't want instability associated with the surgery. And around the time of surgery, people ask, well, how long is the recovery? What can I get back to? I think if someone has a knee replacement, regardless of the type of knee replacement, I'm not one to recommend running or jumping as a form of exercise. So that would be a risky thing, I think, in a knee replacement patient. Early failures can happen. Well, this isn't a perfect procedure, but it's a much better procedure than it ever has been. And that's why we follow our patients so closely, making sure there's no signs of infection, no signs of ligament instability. But ultimately, evaluating patients, appropriately addressing their concerns, and also recommending surgery when we feel appropriate those are ways that we think we maximally increase patients' chance of having a great result. And ultimately, if that means a surgery, then it means a surgery. So that's the presentation. I did want to kind of open it up for questions, as Sarah said before. So are there any questions, or Sarah, maybe you have some questions?
I do. You're so good at just really providing all the information. You've been doing this for a couple of years, so
Yeah.
you were really good at giving us the information about the candidates and how to prevent and do some minimal intervention opportunities there, and why, and then when and why surgery might be the best. And it sounds like really it's just about quality of life for people and really getting them back to a particular lifestyle. So I have a couple of questions, and I guess maybe pertaining to lifestyle. I'm just curious, that made me wonder about, is this typically something that comes up as a genetic issue, or is it an injury or lifestyle? Like, what do you find in that combination?
Yeah, so that's a great question. I think many patients with knee problems have environmental issues which contribute to their arthritis. And if you can think of where we carry most of our body mass, it's, above our, from our hips to our chest, that's the main part of our body. And so, if you think of the discipline of physics, it's the length of the moment arm times the weight, and that's ultimately the force that a specific part of our body would feel. So, patients who have are big, patients who are tall, patients who are heavy, multiply that times the length of their femur. Those people put a tremendous amount of stress on their knees, not as much the hips, but on the knees. So certainly your body habitus can play a role. Injuries, ex-athletes, we see a lot of folks in the clinic who tell me that, I hurt my knee in high school and I've had knee trouble ever since. Well, that's a real entity. But there is no question that your genetics play a role. So I would say in the event, somebody's had a family member who's had a knee replacement, it's not uncommon for that person to experience knee problems. Hips are even more genetically tied to arthritis than the knees. But I think, the things we focus on are trying to treat the symptoms and address the issues that we can change, from a medicine or injection standpoint, decreasing the inflammation, and then also, trying to decrease the effects of body habitus on the joint itself. So low impact exercise is a wonderful way to treat knee arthritis. I'm a big believer in either regular bicycle or exercise bike. The swimming pool is phenomenal. Those are both things that are not going to make the arthritis worse and actually improve how people feel about their function, because having optimally conditioned joints and optimally conditioned muscles really help people with their symptoms.
Okay, great. Thank you. That's very helpful to know that. And maybe you don't know the statistic on this, but I'm curious how often you typically have to do a second replacement if there's issues with the first time around. Does that happen very often, or is it pretty rare?
It's fairly rare. I think, again, if we optimize patients preoperatively and try and make sure that we've done everything to put people in the right position, that they will have success. I mean, the most common reason we have to return to surgery for a knee replacement is infection, unfortunately. So making sure people are healthy, making sure people don't have predisposing health conditions that increase their risk of infection. That would include inflammatory arthritis, people that are malnourished, people that are morbidly obese. Those folks have increased risk of infection. Beyond that, again, we talk about ligament instability. We talk about failure of the implant. Those things are becoming less common because of the techniques we're using. But I would usually estimate for most patients anywhere from a half to 1% per year return to the operating room for a problem with their joint replacement. So, if it's 10 years after surgery, maybe 5 or to 10% of those folks have had a return to surgery for some issue, and 20 years, then it would be 10 to 20%. I think that's a fair estimate.
Great. It sounds like that's very, very rare then in those cases. So curious too, like, do typically people, if they're going to have one knee done, does it usually mean the second one needs to be done also, or is that also kind of not really like correlated together?
Yeah, I certainly, I think if someone has a knee replacement, they are at higher risk to have their other side done than someone who's never had a knee replacement. And that again would speak to exposures in the environment, what kind of stress their knees are under, but also a genetic predisposition. But I do have patients that we've replaced one knee in, and they've done very well with the one knee, and the other knee is either not treated or treated non-operatively. So I think there's increased risk, but I don't think it's an overwhelming risk.
Okay, great. That's helpful.
Yeah.
So, and then just regarding technology advancement, I'm sure, again, you mentioned having been coming here to Boone County Hospital for nearly 20 years, and I'm guessing you may have been in practice even longer than that. What has been, obviously it's very interesting to watch all the advancements happening, but I guess my question was more towards recovery and how you've seen the changes through recovery over the years and how these advancements have helped with that.
Yeah, I think recovery has really been facilitated by multiple interventions. Number one, we do a really good job, we being the orthopedic community, of trying to take care of patients' discomfort, certainly in the perioperative period, but also supporting them afterwards. So, we do multimodal pain control after surgery. That would include preoperatively, many patients have a spinal anesthetic, which allows smoother, sort of waking up after surgery. They don't have pain right away when they wake up. So I think in the moment, people are less uncomfortable. Secondarily, virtually all the patients here at Boone County Hospital have a nerve block around the time of surgery. So not just a spinal, but a nerve block. The anesthesia team here is excellent. They do a wonderful job. And so that nerve block can help. During the procedure, we use medication that we inject into the soft tissues, and that helps perioperatively with pain. We also use medications that decrease blood loss associated with the surgery, and that decreases swelling and decreases bruising, which helps with perioperative pain control. And I think just the techniques we use, limiting trauma to the soft tissues, appropriately having patients see the therapist. I think it's a multi-faceted approach, but there's no question that the recovery after knee replacement now is much smoother than it was when I started 21 years ago.
Yeah, that's great. Yeah, I bet it's been quite a process over the years and learning experience for you as well as these advancements continue. It's just awesome to hear about them. So thank you for that. You're a wealth of knowledge. And I want to end with, I'm not seeing any questions in the chat, so I'd like to end with, can you share when you will be here at Boone County Hospital Specialty Clinic? I think you mentioned at least a couple of days a month you're here.
Yeah, so we do surgery and see patients in clinic the second Monday of every month. We follow up with a clinic the Wednesday after that, so 2 days later. And then either my PA, Casey Howe, or myself are here the fourth Monday of the month. Partners, Dr. Aviles, who I spoke of previously, who is here I believe twice a month, and then my partner Ben Paulson is here, I believe almost every week, seeing patients with hand problems and doing hand surgery. So we try and make it easy for patients to see us here and enjoy working with all the professionals here at Boone County Hospital and enjoy the people of Boone and surrounding communities. So we enjoy it and hope to continue to come up here.
Great. Well, thank you for that so much. And thank you for the compliments back to our rehab team and our anesthesia team. And you know, just really appreciate all that as well and having you all come up here. So I think that concludes us today.
All
Dr.
right.
Mahoney, do you have anything else you wanted to add as we close?
Yeah, I think we're all set. Thanks, Sarah.
Awesome. Well, thanks so much again for your time and knowledge today. And we look forward to seeing you again real soon. Take care.
All right, you too. Bye-bye.
Thanks. Bye.